Now, in the workers' compensation setting and in our evaluations with examinees, there's two basic ways that examinees can exaggerate and overstate their disability. And they do it by just that, by either overstating their symptoms during physical examination maneuvers or by understating their abilities and capacities during physical examination maneuvers. So they say that everything hurts. In other words, they overstate their symptoms and they understate their ability to perform the maneuvers. Oh, that hurts. Oh, I can't do that. Oh, that hurts. And oh, I can't do that. So always be on the alert for situations where the overstatement or understatement is out of context and out of proportion. It's what the DSM-4 referred to as a marked discrepancy with the known physical condition, with the mechanism of injury, and with the medical treatment history to date. Okay? Now, one of the ways that we assess examinees and their consistency and their credibility is by assessing their behavior, their nonverbal communications. So when we communicate with examinees, we communicate with them both verbally and then also nonverbally. So I want to go into a discussion now about assessing the nonverbal pain behaviors. So what are pain behaviors? Well, I wonder if you've ever heard it said that when people communicate, a large percentage of the messages that are conveyed through communication are nonverbal. And sometimes experts in this area give certain percentages to the contribution of body language and the contribution of words to the overall message that's conveyed. And you may have heard it said, for example, and estimates can vary, but you may have heard it said that only 7% of the communication between people is through the words. Now, the words are very important, but the larger percentage, up to 93% of communications, are delivered non-verbally. And pain behaviors are exactly that. They are non-verbal signs that tell us how the examinee is doing, whether they're doing well or whether they're doing poorly. So let's describe the pain behaviors here that are discussed in the AMA guides. And then I want to dissect the pain behaviors with a fine-tooth comb through the means of a live video discussion. So the pain behaviors are described on page 580 of the AMA guides. That's in chapter 18. And they go through many different types of pain behaviors. Now, these are not the only pain behaviors that you could observe. For example, here, one of the pain behaviors that's described in the AMA guides is facial grimacing. Well, the AMA guides don't describe all the different various forms of facial grimacing, but I've broken that down here into several different types of facial grimaces, and we'll talk about these here briefly. But suffice to say that the pain behaviors that are described in the AMA guides are not the only pain behaviors, and you may observe pain behaviors that are not described in the AMA guides, and your observations would be just as valid as any other observation that is described in the AMA guides. Okay? So, for example, with regards to facial grimacing, examples of facial grimacing include a tense face, a restless face, certain tics of the muscles around the face, a grimace, a frown such that pulls the corners of the mouth downwards, a gesture where it looks like the eyes are squeezed, looking sad, almost in tears, a frightened, fearful look, a deeper nasolabial furrow, and a trembling chin, almost as if cold or shivering. And you may observe other forms of facial grimacing in addition to these as well. Okay, other pain behaviors that are described in the AMA guides include holding or supporting an affected body part or area. This we commonly see with upper extremity conditions where the examinee will hold or support one upper extremity with their other upper extremity. Limping or distorted gait. The examinee may or may not present with an assist device. And limping and distorted gait, also known as an antalgic gait, is quite an interesting observation. And it raises the question, what is a limp? What is a limp? A limp is sort of an evasive action away from some pain. Think about a sprained ankle. If you've badly sprained your ankle, you know that when you step down and apply weight to those injured tissues, there's pain, which causes you to get off of that pain, shortening up the stance phase of your gait, and we refer to that as a limp. Okay? So a limp is a pain behavior that serves as a true objective finding for some sort of a bona fide condition. Frequent shifting of posture or position is one of the pain behaviors. This may manifest as the examinee getting up and out of their chair to stand. Perhaps while they're sitting, they shift from one buttock cheek to another. Stretching and craning of the neck, or upper or lower extremity gyrations. And you probably can imagine, and you've probably seen almost every possible example of the examinee gyrating their shoulder, gyrating their elbow, gyrating their wrist, cracking their knuckles. Any form of movement that constitutes frequent shifting of posture or position could constitute the presence, could suggest the presence of a bona fide condition. On the other hand, an examinee who complains of constant severe neck pain and stiffness, but who's observed to have an absence of shifting of posture and an absence of shifting of position, that absence of shifting suggests that they're fairly comfortable and that they don't need a frequent change of position. So these nonverbal communications, both when they're present, in other words, when they're committed, and then also when they're absent or when they are omitted, and there's the omission again, when they're omitted, they speak 1,000 words. So you need to sharpen your attention to the presence and or absence of pain behaviors. And many times the absence of a pain behavior tells you as much, if not more, as the presence of a pain behavior. Other pain behaviors described in the AMA guides include extremely slow movements. If the examinee demonstrates extremely slow movements, make sure that the slow movements are consistent throughout the entire evaluation, both through formal and informal observation of the examinee. Sitting with a rigid posture, again, assess this one for consistency. Moving in a guarded or protected fashion. This is something that we frequently see during physical examination maneuvers. Moaning or letting out other sounds and or utterances such as sighing, such as yelping, such as crying. Sometimes examinees will cry, sometimes they groan, they sometimes emit sounds of restlessness, and you want to assess these sounds for their volume, for their intensity, and for their consistency with the physical examination maneuver that provokes such a sound. If you were to experience an examinee groaning out of proportion to any physical examination maneuver, well, that tells you something. That tells you something. Okay? So there's another thing to be observant for. Using a cane, a cervical collar, or other assistive device. We can refer to these in general just as assistive devices. Stooping while walking, this would be an example of a gait disturbance. And other physiologic signs of pain behavior, such as breath holding, faltering respiration, shocking respiration, looks red or turns red, perhaps from holding their breath, tears, sweating, and other physiologic signs. So pain behaviors are important. Pain behaviors, like pictures, speak 1,000 words. They're nonverbal communications to us, and we need to sharpen our attention and sharpen our awareness to the pain behaviors. Now, I want to spend some time dissecting each of these pain behaviors and giving you many different examples of when these pain behaviors could manifest and when these pain behaviors would be considered to be inappropriate. So I want to go through a live video demonstration with you here regarding the pain behaviors. And this video demonstration is simply entitled The Pain Behaviors. Hi, this is Dr. Perry Carpenter. I'd like to thank you for joining me on today's video. Today's video is part one in a two-part series regarding the pain-related impairment. And we're going to be specifically discussing some topics directly out of chapter 18. And before we get into today's video, I just want to thank you for joining me on this video. And I hope you're enjoying the video series that we are providing for you. You should be receiving a regular video training session from me approximately every 2 weeks if you're a subscriber on my mailing list. And if you're not a subscriber on my mailing list, you can still check our archives for backdated videos. They are available to you, and they're available to you by going to our website, which is www.ezqmeceu.com. So I suggest that you go to that website and check our archive of prior videos. We have over 100 hours of videotape trainings available for you on a wide variety of topics associated with the work that we do as qualified medical evaluators. So again, that's www.ezqmeceu.com. There's a link there that will take you to our entire archive of over 100 hours of QME training videos. Now, for today's video, I want to talk to you about Chapter 18 and the pain-related impairment. And the reason I chose this topic for the next two video training sessions is that I'm receiving many phone calls from doctors who have some confusion about providing for additional permanent impairment due to pain, and that is additional permanent impairment above and beyond the standard impairment that the AMA guides provide for the condition in question. And so doctors seem to have some confusion about this additional discretionary permanent impairment, and it seems that many doctors are providing for pain-related impairment incorrectly. And it's interesting because the AMA guides give us an exact set of procedures to follow in order to provide for additional permanent impairment due to the added burden of pain. And that is the burden of pain above and beyond the standard pain that we expect for a given permanently impairing physical condition, such as a neck condition, such as a shoulder condition, etc. So I want to address that in this video series. Now today, on today's program, we're going to introduce a couple of topics that will establish the theme for the entire video series, and then I want to specifically focus in this video presentation about pain behaviors. Pain behaviors. Because the pain behaviors, we rely heavily on the pain behaviors in providing for additional pain-related impairment. And we as doctors, either knowingly or unknowingly, observe for pain behaviors in arriving at an accurate permanent impairment rating for our examinee. But it seems that there's some misunderstanding about the significance and the interpretation of pain behaviors. So I want to take the pain behaviors today and dissect them under a microscope and give you some understanding as to how you can use your observations of pain behaviors in arriving at a reasonable and accurate permanent impairment rating for your examinee. So for the next two videos, we're going to be largely focused on Chapter 18 of the AMA Guides. And I'm also going to be making some references to the 2001 Physician's Guides. Now, some of you that are new qualified medical evaluators, meaning new since 2005, you might be wondering, well, what in the world is the 2001 Physician's Guide? But for those of you that have been doing QME examinations prior to 2005, you'll remember that the 2001 Physician's Guide used to be the Bible upon which we relied for our practices and principles of doing QME exams. Now that's changed since we adopted the AMA guides in 2005, but the 2001 Physician's Guide still contains some valuable principles and some valuable concepts that will live on probably forever as long as we're involved in this medical, legal, workers' compensation system. So I'm going to make some references also to the 2001 Physician's Guides, and I'm going to draw some parallels between the 2001 Physician's Guide on one hand and the AMA guides on the other hand. And what we're going to see is really that these two references upon which we formerly relied and currently rely basically give us the same instruction as evaluators as to how we provide for permanent impairment. Now it's permanent impairment. It used to be permanent disability before 2005. But whether we're providing for permanent disability for injuries before 2005 or permanent impairment for injuries after 2005, some of the principles that we use in providing for disability or impairment have not changed, and they probably will universally apply forever. So I'm going to draw some references and some parallels to these two books that have guided our practices as qualified medical evaluators for a long time. So that's our agenda for today. I'll give you a minute to go ahead and get your AMA guides. If you have the 2001 Physician's Guide, go ahead and grab that too, because I'm going to have you follow along with me as I point out some significant passages that relate to what we're talking about today, which is the pain-related impairment with specific emphasis on the pain behaviors. So I look forward to being back with you here in just a couple minutes, and we'll dig right in to our discussion of pain behaviors. AMA Guides 5th edition, and I hope you have your AMA Guides as well. And I want to begin today's discussion about the pain-related impairment by talking a little bit about the pain behaviors. And I'm going to shed some new light on how you may have thought about the pain behaviors in the past, and give you some new perspective as to what pain behaviors indicate and how do pain behaviors apply in the assignment of additional permanent impairment due to the added burden of such pain. Okay, so we're going to take the pain behaviors today and put them under a microscope and look at them and go through them with a fine-tooth comb. And I want to introduce some of our topics today with a couple of specific quotes from both the AMA Guides and also from the 2001 Physician's Guide. So let's first begin by saying that when we meet with an examinee speaks to us through two separate and distinct pathways. There is the examinee's verbal communication, and then there is the examinee's nonverbal communication. So examinees will tell us certain things with their words, and examinees will tell us certain things with their body language and their nonverbal communications. So it's the subjective complaints that we get from the examinee through their verbal communication. And then the nonverbal communication in the form of pain behaviors tells us something about their verbal communication. The nonverbal communication can either support or controvert the spoken communication. And as far as pain is concerned, we rely on the pain behaviors to give us some guidance in our assessment of the consistency of the subjective complaints. So pain behavior is rated largely on the basis of an individual's nonverbal behavior. And we assess pain behaviors primarily during the physical exam, but we also assess pain behaviors during our interview, and we observe pain behaviors through our casual observation of the examinee. Casually as they move throughout the examining room, casually as they move to and from the men's room or the ladies' room. And we observe our examinee in a variety of different settings and in a variety of different formats. So when we observe the examinee during the interview, we refer to that as casual observation. When we observe the examinee during the physical exam, we refer to that as direct observation. So we have both casual observation and we have direct observation. And it's during these times that we obtain information about their pain through the expression of their nonverbal communication in the form of what the AMA Guides refers to as the pain behaviors. Okay? Now, a couple quotes from the AMA Guides. The AMA Guides say on page 582, first paragraph, they tell us that the principal gauge of pain is its associated behaviors, which includes reports. What kind of reports? Well, it includes the subjective reports of the examinee. And if you've been doing qualified medical examinations for any length of time, you know that examinees can give you all manner of reports about their subjective complaints. Well, it's our job as the qualified medical evaluator to take the subjective reports that the examinee gives us and translate those subjective complaints into a reasonable impairment rating, if so applicable. And I'll talk about how we do that here as we go on. Now, I want to establish a theme that we're going to develop throughout the course of today's video. And that is, it's the doctor's job to interpret what a person says and put that into context of the actual medical condition. And it's the pain behaviors that sort of act as an interpreter between
what the examinee says subjectively and what our conclusion is that we arrive at objectively. The pain behaviors are the pathway between those two endpoints. And the AMA guides tell us that on certain occasions we can expect that examinees may not be on the same page as us in their verbal communication skills. And we can expect that examinees may overstate their subjective complaints, they may embellish their subjective complaints, they may magnify their subjective complaints. In fact, the AMA guides tell us on page 583 that inappropriate pain behavior, embellishment, and symptom magnification are common, particularly in medical legal circumstances and in entitlement programs. So the AMA guides tell us that in medical legal circumstances, such as in the qualified medical exam, we can expect, in fact, it's common, the guides tell us that it's common to experience or witness inappropriate pain behavior, embellishment, and symptom magnification. And we'll talk about why an examinee would over-elaborate their symptoms in just a minute, but you need to prepare yourself mentally in advance for the possibility that your examinee could overstate their symptoms. The AMA guides tell us to anticipate that in advance, okay? And it's the pain behaviors that are going to give us true insight as to the examinee's current condition, is insight into the examinee's true condition, an accurate insight into the examinee's true current condition, okay? Now, the pain behaviors are described on page 580, and we're going to go through the pain behaviors painstakingly here one at a time in just a minute. But before we even get to that, I want to draw your attention to a couple more quotes from the AMA guides, and I want to draw some parallels between what the AMA guides say and what the 2001 Physician's Guide says about pain. On page 579, second column, first paragraph, states that pain behaviors are ways that individuals communicate about their pain. These behaviors may be verbal or nonverbal, and as we said, pain behaviors are primarily nonverbal. Now, some individuals appear stoic as they go through evaluations, and the pain behaviors that they do demonstrate are concordant with other medical information revealing their condition. Well, what does concordant mean? Concordant means that the pain behaviors are in agreement with other medical information regarding their condition. Concordant means that the pain behaviors have the same characteristics as other medical information regarding their condition. So the guides tell us that some examinees, they present pain behaviors that are in agreement with what you would expect for a person with their presumed medical condition. Now the guides tell us that at the opposite extreme of this is that an individual may demonstrate pain behaviors that appear exaggerated and that appear discordant. Discordant means not in agreement, not having the same characteristics. So they may demonstrate pain behaviors that appear exaggerated and discordant with his or her presumed medical condition. The guides tell us that we can expect examinees to, on occasion, present with pain behaviors that are not in agreement with what you would expect as the doctor going into the evaluation, knowing in advance about their presumed medical condition. See, we as medical evaluators, we go to the examination with a preconceived notion about how a person with a presumed medical condition, let's just call it condition A, condition B, condition C, we go into the evaluation with a notion of how a person with that condition would act, should act, and is supposed to act. And many times the examinees, because they don't have our background, they don't have our training, and for a variety of other reasons, they present to us pain behaviors that appear exaggerated or that appear not consistent with what we understand as doctors, as to how we understand the presumed medical condition. So we can expect that. Well, the guides tell us that these pain behaviors may appear to be driven by a variety of factors. In fact, you might be wondering to yourself, well, what would drive a person, or what would cause a person to demonstrate exaggerated pain behaviors? What would cause an examinee to demonstrate pain behaviors not in accordance with what I would expect for a presumed medical condition? What would cause examinees to basically behave in strange ways? Well, the guides tell us, the guides give us two reasons, and I'm sure that we could come up with probably a dozen reasons, but the guides shed some light on this by illustrating two different scenarios. The guides tell us that these pain behaviors may appear to be driven by a variety of factors, such as overwhelming somatic anxiety, or the person's desire to convince an examiner that he or she is suffering greatly. So let's just talk about this for a minute. The guides say that overwhelming somatic anxiety or the desire to convince the examiner that they're suffering greatly are two possible reasons why an examinee may exaggerate their pain behaviors. Well, let me ask you, in your experience as a qualified medical evaluator, have you ever had an examinee present to the evaluation a little bit anxious? I'm sure you have, right? And you'll probably agree with me that examinees present to the evaluation with the whole range of anxiety, from being just a little bit anxious about the unknown and the uncertainty of going to a qualified medical evaluation, all the way to what the AMA guides describe as overwhelming somatic anxiety. And I'm reminded of an examinee that I had one time who I would say actually qualified as being overwhelmingly anxious. In fact, this examinee was sweating profusely throughout the entirety of the interview process. He was sweating from his forehead, he was sweating from his underarms and staining his shirt badly in the underarms and down the middle of his back. The examinee insisted and persisted in continuing to move out of my line of vision, and eventually came to stand at a position almost behind me. And I kept having to turn my body in order to be able to have any reasonable observation of him. And he was overwhelmingly anxious. Well, some examinees present with just a little bit of anxiety about being at the evaluation, and we come to consider this as normal. And I want to emphasize to you that your examinees do present to your evaluations a little bit anxious, and there's a variety of reasons for that. Number one, they're stepping into the unknown, which I don't know about you, but that always makes me anxious. There's the uncertainty of what's going to happen. Many times they're required to attend these evaluations when they don't want to. They have to take time off work, and there's a variety of situations and reasons as to why the examinee would be a little bit anxious in coming to your evaluation. So you need to anticipate that in advance. And our job as the evaluating doctors is to comfort the examinee and to allay their anxiety so that we can get to really the bottom line and get to the truth of their condition. And by allaying their anxiety, we minimize They're expressions of exaggerated pain behaviors. If we can calm them down and make them comfortable in our presence and in the environment, the opportunity and the need for them to demonstrate exaggerated pain behaviors diminishes. So you need to make the examinee comfortable. Now, the AMA guides then refer to a second situation, whereas the examinee uses exaggerated pain behaviors in an attempt to convince us, as their evaluator, that they're suffering badly or that they've suffered greatly as a result of this terrible situation of being involved with workers' compensation. Now, let me ask you, in your experience, do examinees typically suffer badly? Do they suffer greatly in the workers' compensation system? Well, arguments on that could differ, but in my experience, many times examinees do suffer greatly. For one thing, they perceive that the medical care that they've received may have not been ideal, may not have been perfect for the condition that they've suffered. Many times examinees tell me that when they go to the doctor doesn't listen to them. They tell me that when they go to the doctor, they're never seen by the doctor, they're only seen by the assistant, or that every time they go, they're seen by a different person at the doctor's office, and they feel that the doctor doesn't listen to them, and weeks and months and sometimes years go by, and in their experience, they're suffering greatly. They might not be getting the care that they need, they may have ongoing pain and other administrative issues, and from their perspective, they feel as if they've suffered greatly. And by the time they get to your evaluation, they're hoping that you could be their savior. You could be the last person to potentially be in a position to help them. And so their over-exaggeration or over-elaboration of symptoms is simply an attempt to get your attention, to shake some sense into someone in this system, to let them know how badly they're suffering. And, you know, in my experience as a qualified medical evaluator doing examinations since 1995, I've actually come to accept some degree of symptom magnification and some degree of embellishment to be normal, exactly for the reasons that are described here in the AMA guides. And that is that by the time the examinee gets to you, sometimes a year has gone by, sometimes 18 months, 2 years, 3 years. I've had cases, 10-year-old cases, and I know you have as well. And so by the time the examinee finally gets to you, they let you have it with full force. And sometimes in that circumstance, some embellishment is to be considered normal. Now, the bottom line for us as examiners is that it's our job to translate the examinee's communication, both verbally and non-verbally, and come up with a conclusion that's an accurate representation of their true condition. So for that, we rely on the pain behaviors. So let's talk a little bit about the pain behaviors and put the pain behaviors under a microscope. So we've established that the AMA guides tell us that it is possible to expect some degree of symptom magnification and some degree of embellishment of both subjective complaints and pain behaviors in our examinees. Well, the 2001 Physician's Guide provides us some similar guidance. And I just want to read for you a couple quotes from the 2001 Physician's Guide before we get back into the AMA guides and dissect the pain behaviors. Now, in times before 2005, let me just give you a little bit of historic philosophy. Before the adoption of the AMA guides in 2005, we used to provide for permanent disability rather than permanent impairment, which is what the guides instruct us on now. Well, before 2005, one of the components of permanent disability was what was referred to as the subjective factors of disability. And the subjective factors of disability included the doctor's description of the examinee's level of pain and the various types of activities that pain interfered with. Now, the 2001 Physician's Guide counseled and coached doctors on how to translate the verbal communications from our examinee and to convert their descriptions into a language that was spoken in the workers' compensation system. And so we use terms in the past such as occasional slight pain, occasional moderate pain, frequent constant pain, and we attempted to define pain by using terms that everyone could agree upon. In those days we called those the terms of art. So I want to read to you just a little bit about what the 2001 Physician's Guide says. And then I'm going to put that in the context of the pain behaviors that are described in the AMA guides that we use today. So on page 43 of the 2001 Physician's Guides, they're talking about pain. And they state here that pain is an unpleasant sensory and emotional experience. It's associated with actual or potential tissue damage, or it's described in terms of such damage. Now, pain is not readily measurable or objectively validated. Consequently, the evaluation, the management, and the disability evaluation of pain disorders depend on the assessment of an individual's verbal and nonverbal behavior. So we use the pain behaviors all the way back into antiquity, even before the adoption of the 2005 Physician's Guide. So some of what I'm going to tell you today is not new. It really has not changed since the beginning of time when we began doing qualified medical evaluations. So how does that relate to the pain behaviors? Well, the pain behaviors are described on page 580 of the AMA guides. Turn to 580. Table 18.5 describes some pain behaviors. Now, table 18.5 does not include every possible pain behavior that we could expect to see in an examinee, but it gives us some examples of pain behaviors that are commonly displayed. So let's review these pain behaviors. And as we go through the pain behaviors, I want to take you through an exercise regarding the pain behaviors. And we're going to dissect these pain behaviors down and take a look at them closely as to what the pain behaviors demonstrate, what are the physical conditions that could cause each of these pain behaviors, and what kind of positive objective findings we would expect to see on physical examination in the presence of each of these pain behaviors. Okay, so let's just list the pain behaviors that are described in the AMA guides. The first one is facial grimacing. Second one is holding or supporting affected body parts or body areas. The third is limping or distorted gait. The fourth is frequent shifting of posture or position. The fifth is extremely slow movements. The sixth is sitting with a rigid posture. 7 is moving in guarded or protective fashion. 8 is moaning. 9 is using a cane, cervical collar, or other assistive device. 10 is stooping while walking. And then number 11 is where the AMA guides give us all the latitude in the world that we need to describe other pain behaviors that we may observe in our examinee, and they simply refer to that as other. So this would be where in your report you would describe and even summarize your examinee's pain behavior. Now, as we consider these 10 specific and number 11 general different pain behaviors, I want to take you through an exercise. And in fact, I want to take you through 5 different exercises. And we won't go through each exercise with each of the pain behaviors. We'll select out a few key pain behaviors. But the exercises that I want you to consider as you imagine in your mind an examinee demonstrating each of these pain behaviors, I want you to ask yourself the following question. Number 1, which of these pain behaviors would you expect to see more during the interview? And which of the pain behaviors would you think would manifest more likely during the physical examination? Now, what we're going to see is some of these pain behaviors are pain behaviors that should only be elicited during the physical exam, and some other pain behaviors we could observe in casual observation during the interview. So we'll sort of separate out the pain behaviors as to where we would most likely see those during the course of our evaluation with the examinee. Exercise number 2 is which of the above pain behaviors number 1 through 10 as we discussed, can be generally associated with pain, and which are associated with specific pains. Maybe another way to say that is, which of the above pain behaviors are associated with general pain throughout the body, and which are associated with specific conditions or specific pains. Certain pain behaviors are very specific to a specific condition, whereas other pain behaviors could be demonstrated just generally when the examinee just generally does not feel well. So we have general pain behaviors and we have some pain behaviors that are very specific, and we'll talk about those. Exercise number 3 is to identify the type of condition that could cause the pain behavior. For example, some of these pain behaviors are associated with very specific conditions. Some pain behaviors we would see with a cervical spine injury, but we wouldn't expect to see with an extremity injury. Okay? So some of these pain behaviors you're going to see sometimes in your examination that the pain behavior is discordant. See, the AMA guides tell us that the pain behavior could possibly be not in agreement or discordant with the presumed medical condition. So we need to establish firmly in our minds, what would some associated pain behaviors be with the various medical conditions that we evaluate? And we'll talk about that. Exercise number 4, which of the above pain behaviors are pathognomonic for certain conditions? Or ask another way, we could ask, what conditions that we commonly evaluate in the qualified medical examination, what conditions have pathognomonic pain behaviors? And let me give you an example. Imagine an examinee with bona fide L5 radiculopathy. Bona fide L5 radiculopathy. Well, we know that a bona fide L5 radiculopathy that involves injury and damage to the motor nerves, the motor neurons, can cause weakness of the anterior tibialis muscle. This manifests itself in the pain behavior that the AMA guides describe as limping or distorted gait. So what is the distorted gait associated with weakness of the anterior tibialis muscle? Well, we refer to that as a steppage gait, right? Or we refer to that as a drop foot. So when you see a drop foot is pathognomonic for a limited population of conditions. Okay, so how many different types of conditions can we see that manifest as a drop foot? Well, perhaps a direct injury to the anterior tibialis muscle, such as a contusion, perhaps L5 radiculopathy, perhaps an injury to the peripheral common peroneal nerve. In other words, when you see a drop foot, when you see someone walking along with a distorted gait like a drop foot, that drop foot is pathognomonic for the condition. And some of the pain behaviors that are listed here in the AMA guides are pathognomonic behaviors. And some of them are just general behaviors that indicates that the examinee is not feeling well, is having general pain throughout their body. And we'll separate those out. And then finally, I want you to ask yourself, as you look at each of these pain behaviors, which of these pain behaviors should be accompanied by true positive physical examination findings on your physical exam? And what would some of those positive objective findings look like? And what would some of those positive objective findings be? In fact, the pain behaviors should be accompanied by true positive objective findings, correct? And the true positive objective findings on examination should coincide and should be consistent with the pain behavior. For example, in going back to our example of L5 radiculopathy, if you see an examinee walking with a drop foot, right, presenting the pain behavior of limping or distorted gait, what would you expect on physical examination? Well, if you go to physical examination and you do manual muscle testing of the ankle dorsiflexors, the foot and ankle dorsiflexors, and they're strong, that would be an inconsistent physical examination finding. That would be disconcordance between the pain behaviors and the physical examination findings. And it's our job as the doctor to establish the consistency or the inconsistency in arriving at our final conclusion. Okay, so those are our exercises. We'll go through those in just a minute. Before we do that, I just want to say a couple more comments about the pain behaviors. And the AMA guides give us extra latitude with category number 11, which they simply refer to as the other category. Well, what would some other pain behaviors be? What are some other pain behaviors that we could expect examinees to present with throughout the course of our evaluation of them, in addition to those that are already given in Table 18-5? Well, I want to talk about a specific set of pain behaviors that we refer to as the apprehension signs. And in physical exam, we refer to some of these examination maneuvers as apprehension tests. So I want to talk a little bit about true positive objective findings. Now, in actuality, each of these pain behaviors represent true positive objective findings. In the presence of bona fide painful conditions, many of these pain behaviors would represent a true positive objective finding. And really what these pain behaviors are simply pain avoidance maneuvers, postures, positions, or actions. Take, for example, limping or distorted gait. What is a limp? Let me ask you, have you ever sprained your ankle? Well, you know that when you sprain your ankle and there's ligament damage, you know that there's edema, there's nociceptive metabolites that are released by damaged cells, and there's pain. And we know that pain is inhibitory to alpha motor neurons. Pain makes the ankle weak. It's inhibitory to the muscles involved with gait. So when a person with a fresh sprained ankle walks, they walk with a limp. The limp is a true objective finding. It's a true pain avoidance mechanism that keeps the painful ankle from worsening itself. So a limp in that circumstance is a true objective finding. You wouldn't expect to have a person with a badly swollen and edematous ankle with a fresh ankle sprain to be able to walk normally. That would be discordant. So in that sense, the limp is a true positive objective finding. What about stooping with walking? Stooping with walking. Have you ever known a person that has progressive spinal stenosis, degenerative spinal stenosis? Well, we know that spinal stenosis drives the spine into lumbar flexion, because it's the lumbar flexion that creates the maximum amount of clearance for the descending spinal nerve roots, the cauda equina. Well, the reason that the person is driven into flexion is because extension hurts. And the movement into flexion is an antalgia. It's a movement away from pain. It's a true objective finding. Well, most of the pain behaviors are true objective findings in the presence of bona fide painful conditions. Well, the apprehension signs are also true positive objective findings, and I want you to increase your awareness and increase your alertness to be observant for apprehension signs. So what are the apprehension signs? Well, we're familiar with the apprehension signs in the shoulder with shoulder apprehension testing, and we're also familiar with the apprehension sign in the knee for assessment of patellar instability. And what our orthopedic textbooks tell us about apprehension signs is that the apprehension signs are muscular defenses. Muscular defenses, they're involuntary muscular defenses away from a painful stimulus. So with regards to the shoulder, with testing for shoulder instability, in the presence of bona fide instability, as the shoulder begins to sublux out of the glenoid cavity, whether it be a subluxation or even a dislocation, as that shoulder starts to move out of its congruity with the socket, there are muscular defenses that maneuver the shoulder into a position back into congruity. That's what an apprehension sign is. So let me demonstrate that to you. With shoulder apprehension testing, we take the examinee and we put the shoulder in abduction and we progressively move the shoulder into shoulder external rotation. Now, in the presence of bona fide instability, as the shoulder begins to sublux out of the humeral head, that sends a reflex, involuntary withdrawal reflex that causes the examinee muscular defense. What is the muscular defense? The muscular defense is a movement away from further subluxation. It's a muscular defense that maneuvers the arm or the person into a position of greater congruity of the opposing joint surfaces. What about with patellar instability testing? With patellar instability testing, we maneuver the patella laterally in the trochlear groove in an attempt to assess for instability of the patella in the trochlear groove. Now, in the presence of true instability, perhaps damage to the medial patellofemoral ligament or weakness of the vastus medialis muscle, as the patella begins to sublux out of the trochlear groove, that will be accompanied by an involuntary muscular defense. The purpose of the muscular defense is to draw the patella back, back into the trochlear groove and prevent the potential dislocation of the patella out of the trochlear groove. It's an involuntary, reflexive muscular defense. In fact, it's a subset, or it can be thought of as a form of flexor withdrawal reflex. Flexor withdrawal reflex. If you've ever touched your finger to a hot stove, you know that there's an involuntary and instantaneous reflex to pull the finger away from the painful stimulus, which is the hot stove. So the flexor withdrawal reflex is due to reflexive contraction of agonist muscles, in this case the biceps brachii muscle, which flex the elbow to withdraw the hand from a painful stimulus. So in many of our physical examination maneuvers, we need to be alert for apprehension signs and various forms of flexion withdrawal reflexes. And in fact, the pain behaviors are just forms of flexor withdrawal reflexes in an attempt of the examinee to prevent additional or further pain. Okay? So let's review these and discuss those in the context of a true bona fide painful condition. Let's talk about facial grimacing. We won't talk about each of these. We'll just highlight a couple of the key ones. Let's talk about facial grimacing. The first exercise is, do you think you would see facial grimacing more during the interview or more during the physical examination? Let me ask you. Well, what would cause facial grimacing? Facial grimacing is caused when the painful part is stimulated, and when pain is stimulated in the painful part. When the part is generally quiescent and quiet, it's not pain productive. So in general, and there are exceptions, but in general, you would expect to see facial grimacing more on the physical examination than during the interview. Now, I can imagine scenarios where the examinee has, for example, bad lower back pain, and during the interview, as they maneuver around in their chair, perhaps to get comfortable, you may see facial grimacing as they attempt to maneuver themselves in a way to reduce pain. That could manifest itself during the interview, but most commonly, we're going to expect to see facial grimacing during the physical exam, when we're actually involved and engaged in moving and maneuvering and testing the injured body part. And let me give you an example from my own experience about facial grimacing. I remember a time when I myself had true pain. I was 12 years old and I had a burn on the medial aspect of my right calf from motorcycle exhaust, and had third-degree burns there. And this burn required treatment, and I eventually ended up having a skin graft over the burn. But before they could apply a skin graft, there was some work that needed to be done in order to prepare the site to receive the graft. So for about 3 weeks, I think it was, and my memory fades a little bit because I think I was 12 years old at the time, so this goes back probably about 4 decades. But anyway, they had to do this procedure on my calf that involved debriding the dead skin away from the recipient graft site. And this had to be done about every 3rd or 4th day. So in between treatments, the doctor applied a bandage around the calf And between treatments, I was fine. I was continuing to play. This was during summer vacation, so I carried on basically mostly normally, except for the fact that I had some gauze bandage around my leg. No pain behavior at rest. Now, when I went in to see the doctor, it was a different story. And the doctor had to do this procedure that involved unwrapping the gauze and then debriding away dead skin from the burn site. And this procedure was extremely painful. Even though I forget some of the details about it because it was so long ago, I remember the pain. It was extremely painful. And I remember even on one treatment, my mom, who was there with me at the treatment, my mom actually fainted. My mom was there witnessing me writhing and wriggling and facial grimacing on the table. And she hyperventilated herself and she actually fainted. And so that was a true facial grimace in the presence of true bona fide pain. And so when you provoke an injured body part and a painful body part, typically during the physical exam, you would expect to see facial grimacing. Now, facial grimacing should be consistent throughout the different examination maneuvers that stimulate the painful part. So I would expect that we would see facial grimacing, bona fide facial grimacing, more during the physical exam than during the interview. Well, what about holding or supporting affected body parts or body areas? Would you expect to see that more during the interview process or more during the physical exam? What kind of scenarios can you imagine? Well, I'm reminded of an examinee that I had one time who presented to the examination with an upper extremity complaint, and she came in holding her upper extremity in her other hand like this. And she persisted through the entirety of the interview by holding her upper extremity like this. So that was present during the interview. And the consistency of this pain behavior was corroborated by her physical exam, wherein she allowed only very little movement, and especially movement down here of her shoulder. What about during physical exam? What would be an example of holding or supporting an affected body part? How about a person with cervical spine complaint? Imagine a person with painful and weak cervical spine lying supine on your examination table, and then when they go to rise up from the examination table, they bring their head and their cervical spine along with them by applying support through the hand. That would be an example. How about an examinee who moves one of their lower extremities by using their hands to move the lower extremities? Those would be some examples that I can think of. What about frequent shifting of posture or position? That's a pain behavior. Now, the purpose of frequent shifting or changing of posture or position is to relieve pain, or is to avoid further pain, or to get away from pain. So this is something that we could expect to see during the interview, as the examinee sits with us for an extended period of time. So how would that look? Well, one scenario that comes to mind is an examinee that has lower back pain. That examinee could frequently shift around in their chair in order to get a different position or a different stress on the lower back. What about an upper extremity case? Would we expect to see a person frequently shifting their upper extremity? Probably not as common as we would expect to see perhaps with a lumbar spine case, correct? I guess it is possible that a person perhaps with an elbow condition might need to move their elbow in various positions to get relief throughout the course of the interview. What about during the physical exam? Can you think of some scenarios where The examinee would display frequent shifting of posture or position. Probably not as common. I guess you could think of a scenario where perhaps an examinee is lying supine on the examination table and needs to wiggle around occasionally in order to relieve the buildup of pain in their lower back. But I would expect that this is something that we would observe mostly during the interview process. Okay, and I want you to go through the remainder of that exercise and ask yourself, well, what about extremely slow movements? What about sitting with a rigid posture? What about moving in a guarded or protective fashion? You go through all the pain behaviors and just picture in your mind how that would look. How would that look during the physical exam? How would it look during the interview process? Some of these are going to be more seen during the physical exam and would be considered inconsistent to witness those during the interview process. Exercise number 3 is to identify the type of condition that could cause the above pain behavior. So let's go back to some of these pain behaviors. And let me ask you, what kind of a condition do you think would result in limping or distorted gait? What kinds of conditions could manifest themselves as the pain behavior of limping or distorted gait? Well, limping and distorted gait can be caused by a variety of conditions, including neurologic conditions, both central nervous system conditions and peripheral nervous system conditions. Can be caused by specific conditions with the lower extremities themselves. We would not expect to see limping or distorted gait with a facial laceration. Okay, so I know that's a ridiculous example, but it illustrates the point that some of these pain behaviors are specific to certain conditions. We wouldn't see a limp with a facial laceration. Okay, so if you see an examinee that's demonstrating a limp, it should correlate very specifically with a limited number of possible conditions. What about using a cane or other assistive device? That should be associated with a very specific condition, correct? Okay. What kind of a condition would you expect a person to have who moves in a guarded or protective fashion? Let's consider a person that moves in a guarded or protective fashion around the cervical spine. Let's say during the interview you observe the examinee to be moving their head and neck in a very protective fashion. True objective finding, correct? This would qualify as reduced range of motion of the cervical spine, correct? What kind of condition could result in that finding? A limited number of things. It wouldn't be related to an elbow injury, correct? So if you see this type of behavior when you're examining for an elbow injury, that would raise your eyebrows for perhaps an inconsistent finding, which the AMA guides told us we can expect those in these medical legal evaluations. Let's go on to exercise number 5, and that is, which of these pain behaviors should be accompanied by true positive objective findings? True positive objective findings on physical exam. Now, I stated earlier that these pain behaviors themselves represent true positive objective findings in the presence of a bona fide medical condition. But let's say you had an examinee who was observed to be stooping while walking. Stooping while walking. What kind of positive physical exam findings would you expect to see in this particular examinee? Let me ask you. What if this examinee goes through dorsolateral range of motion and has full range of motion in lumbar extension? Let's say they have extreme range of motion, lumbar hyperflexion. That would be an inconsistent finding, correct? Would you expect an examinee who has stooping while walking, would you expect them to be able to lay completely flat, supine on the examination table? That would be a position of relative extension for their spine compared to lumbar flexion, also known as stooping, correct? Would you expect that examinee to be able to lie comfortably or to allow you to put their spine into lumbar extension? That would be an inconsistent finding. A consistent finding on an examinee that has stooping while walking, lumbar flexion, would be an examinee who, when they go into lumbar extension, won't go, won't go. That would be a consistent physical exam finding, correct? What kind of positive objective findings would you expect to see in an examinee, for example, who is holding or supporting an affected body part? Let's say you have an examinee holding or supporting their upper extremity due to some claimed shoulder pain. Would you expect that examinee to then go through full ranges of motion in all planes? Or would you expect that examinee to demonstrate range of motion consistent with holding or supporting? They would have extremely tentative and limited range of motion. They would have very little strength on resisted manual muscle testing, at least in certain planes. They might have better strength in certain planes, but in other planes would be extremely weak. It's so weak that they have to hold it themselves with their opposite extremity. Physical examination findings should be consistent with the pain behavior. Okay? And I want you to complete this exercise yourself by going through the pain behaviors and thinking, what type of condition would I expect to see this pain behavior? And if I see this pain behavior, how would that manifest on physical examination? And what other positive objective findings would I expect to see on physical exam? And the purpose of these exercises is very simple. The purpose of these exercises is to help you as the examining doctor to put into context the examinee's subjective complaints and translate those subjective complaints into a permanent impairment rating, both under the strict application of the guides and in certain circumstances by providing for additional impairment due to pain under Chapter 18. So it's our responsibility to translate what the examinee is telling us into a true impairment rating that's an accurate reflection of the examinee's condition. And the AMA guides tell us that many times we as the evaluators have to downgrade the impairment rating because examinees present to these evaluations many times anxious and many times frustrated, and as a result they over-embellish and magnify their condition. Okay, so I want to now provide some final comments about pain as we bring this particular videotape to a conclusion. Okay, so let's bring this training session to a conclusion with just a couple of final remarks. And I again want to draw some parallels between the AMA guides and the 2001 Physician's Guide. Now, in the 2001 Physician's Guide, which was the Bible that we used prior to adopting the AMA guides in 2005, there was some concepts regarding pain in the 2001 Physician's Guide that we used when it came to assessing what we called at the time the subjective factors of disability. And in those days, we described pain as one of four major types of pain. There was minimal pain, slight pain, moderate pain, and severe pain. Let me just read the definitions of those to you, and then I'll tell you what the AMA guides say about minimal, slight, moderate, and severe pain. The 2001 Physician's Guide says that a minimal pain, by definition, is pain that would constitute an annoyance, but would cause no handicap in the performance of the particular activity and would be considered a non-rateable permanent disability. We don't rate permanent disability now. Now we rate permanent impairment. But in the day, a minimal pain, it was an annoyance, but it would cause no handicap in the performance of the particular activity. What activity? What activity could cause a minimal pain? Well, I'll shed some insight on that in just a moment. A slight pain, by definition, is a pain that could be tolerated, but would cause some handicap in the performance of the activity precipitating the pain. What activity? Well, it's the activity that precipitates the pain. Aren't there some physical examination maneuvers that we do that precipitate pain? So we can use these definitions and apply them to our physical examination maneuvers to come up with a construct as to how bad the pain is and whether or not the pain interferes with activities. With AMA guides, we're concerned with activities of daily living. We weren't considering activities of daily living prior to 2005. We were just considering activities in general, but the same philosophies regarding slight, minimal, moderate, and severe pain apply to the 2005 AMA Guides 5th edition. A moderate pain could be tolerated, but would cause marked handicap in the performance of the activity precipitating the pain. Marked handicap. A severe pain would preclude the activity precipitating the pain. Now, many times examinees will come to the examination and they will tell you that they have severe pain. They will tell you that the pain is severe. And to them, the pain is severe. They're being truthful with you that the pain is severe. But by definition, according to the definitions that we used to use, their pain is not severe. Severe pain, by definition, is pain that precludes the activity. So let me give you an example. If I told you that I had pain in my elbow, I have severe pain in my elbow. It's severe pain. And I have that pain. When I bend my elbow, it's very painful. Painful in the elbow. That qualifies, by definition, as minimal pain, because the pain does not interfere with the activity, which is elbow flexion, that precipitates the pain. See, when I bend my elbow, ow! Ow! That precipitates the pain. But the pain does not interfere with the activity that causes the pain. By definition, that is what we call a minimal pain. Now, that's different from there's a sharp pain in there. Cannot do it. That is moderate to severe pain. because the pain prevents the activity that causes the pain. What about lumbar range of motion exercises? Many times examinees will tell you that they have pain with various ranges of motion. So the examinee will go into lumbar flexion and say, oh yeah, that hurts. And they'll do lumbar lateral flexion the other way and oh, that hurts. And you note that there's full range of motion in lateral flexion bilaterally. By definition, that's a minimal pain. Now, examinees will tell you that the pain is severe, but in actuality, by definition, the pain does not interfere with the activity, and so therefore, it's minimal pain only. Well, what is minimal pain? What do the AMA guides say about minimal pain? Well, in slightly different language, but using the same concept, on page 5, the AMA guides say, a 0% whole person impairment rating is assigned to an individual with an impairment if the impairment has no significant organ or body system functional consequences and does not limit the performance of the common activities of daily living. When pain is present but does not interfere with activities of daily living, it qualifies as a minimal pain. And for minimal pain, the AMA guides provide for 0% whole person impairment. So these are some ideas that you can rely upon in your physical examination. We look for pain behaviors, and we look for whether or not pain interferes with the various activities involved with the physical examination. If an examinee reports pain with shoulder range of motion, but has no limitation in range of motion, that tells you how severe the pain is, regardless of what the examinee uses in terms of words to describe the severity of the pain. Because the AMA guides tell us that most examinees will over-exaggerate and embellish their symptoms. Now, there are some examinees who won't, but there are some that will. The guides tell us that we can anticipate that, and we can use these two concepts, the concepts of the pain behaviors and the concepts of minimal, slight, moderate, and severe pain, or whether or not the pain interferes with the activity that causes the pain, to give us as the examiners some insight and some idea as to the severity and the true nature of the medical condition. So doctors, I hope this helps you. We're going to expand on some of these concepts in the next video as we go through the physical steps and procedures involved in providing for additional impairment related to pain. But as I said at the beginning of this video, the AMA guides are clear that the permanent impairment ratings provided for in the various chapters should be fairly accurate representatives of the examinee's true impairment, because the permanent impairment ratings consider the subjective complaints and consider the impact of the pain on the ability to perform activities of daily living. Now, there are some circumstances that will qualify for additional discretionary impairment due to pain, and we'll discuss those more fully in our next video. So I hope this has been helpful for you, doctors. I look forward to being with you on the very next video and many videos into the future. This is Dr. Perry Carpenter. I'm wishing you the best of success in your career as a qualified medical evaluator.